Welcome to the Authority File. I'm Bill Mickey, your host and the editorial director at Choice. In many ways, the response to COVID-19 has been a wake-up call for citizens and governments around the world. In the last 10 months, researchers tracking data related to the spread of COVID-19 have come to a new understanding of how policies, legal systems, and governance have responded to the virus and how these have exposed vulnerabilities in our infrastructure, institutions, and most importantly, the people who are most susceptible to the virus and more likely to die from it. In fact, the manner in which many countries implemented their COVID-19 responses actually exacerbated vulnerabilities in certain populations. My guests for this series have compiled a volume that explores one country's response to COVID-19, Canada's. It's written primarily from a legal perspective, but grounded in governance, accountability, civil liberties, equity, labor, and global health. The book is called Vulnerable: The Law, Policy, and Ethics of COVID-19, published by the University of Ottawa Press, the sponsor of this series. While the title focuses on Canada's response to COVID-19, it includes a global health perspective on the ways in which governments can and should prioritize their policies in responding to and recovering from a pandemic, pulling together experts in law, ethics, philosophy, public health, and medicine. Joining me are the book's editors. Colleen Flood is the University of Ottawa Research Chair in Health Law and Policy and inaugural Director of the Ottawa Centre for Health Law, Policy, and Ethics. Vanessa McDonald is Associate Professor at the University of Ottawa Faculty of Law and Co-Director of the U Ottawa Public Law Centre. The Honorable Jane Philpott, who is Professor of Family Medicine, Dean of the Faculty of Health Sciences, and Director of the School of Medicine at Queen's University in Kingston, Ontario, and served as Canada's Minister of Health from 2015 to 2017, and then Minister of Indigenous Services from 2017 to 2019. Sophie Theriault is full professor and vice dean in the Faculty of Law at the University of Ottawa, and Sridhar Venkatapuram is an academic practitioner in global health ethics and justice. He is associate professor at King's College London and director of global health education and training at the King's Global Health Institute. Since we were fortunate enough to speak with the whole team of editors for this series, we're dividing the group among the 4 episodes. In the first 2 episodes, we heard from Colleen Flood and Vanessa McDonald, who examined the pandemic response from governmental and legal perspectives. In episodes 3 and 4, we're joined by Jane, Sophie, and Sridhar, who address issues of equity and vulnerability. This is episode 3 of the series. If you missed the first 2 episodes, feel free to go back and listen to them and then pick up the conversation here. So, here are Jane, Sophie, and Sridhar. All right, everybody, welcome to the program. Thank you for being with us.
Thanks for having us.
Thank you.
All right. So Jane, we'll start with you. In the book, you wrote about a specific case study involving Participation House Markham, a group home for adults with a variety of developmental disabilities. I'm wondering if you could just briefly describe the crisis the facility was faced with back in April of this year.
Yes, I'd be happy to tell you about that. So I'm a family doctor by background and had just finished being in politics for 4 or 5 years, and am now in a role as an academic dean, but had a bit of time in between around the time that the pandemic started. And this was essentially early April when the spread was significant here in Canada. And I was working at a COVID assessment center. And on Easter Sunday morning, I got a text message from a friend saying, the executive director of Participation House is in a panic because 95% of their residents of the group home are positive with COVID and they can't get any help. What should they do? So I literally got in my car and just drove down there. The place is about 15 minutes away from where I live. It's a home for adults with severe intellectual and developmental and physical disabilities. And as I said, out of 42 residents, 40 of them were positive with COVID. They had about 100 staff members, and overnight 90 of the staff had to leave, either because they were sick themselves or because they had been potentially infected, or they worked in another facility and couldn't work in more than one. So suddenly you have 40 very disabled adults who are completely dependent upon others for being fed and dressed and bathed. Many of them quite sick with COVID, and 90% of your staff has left. It was an extraordinary challenge. It Because of the way things work here in Canada, it doesn't fall under the Ministry of Health. It fell into the Ministry of Community and Social Services. So they weren't getting response from the Ministry of Health to their pleas. And so I was the family doctor. I essentially rolled up my sleeves and started assessing people, started to try to attract support to be able to get the nurses and personal support workers that were necessary, and care for some very, very sick people. It was early days in the pandemic, and it was an experience I will never forget.
Yeah, I mean, that sounds really intense. Just sticking with you, Jane, I'm wondering, based on that experience, what or what were some of the challenges on the front lines that tend to get missed or glossed over as leadership, whether regionally or at federally, focus on large scale solutions. How can facilities like Participation House be be better served or prepared moving forward?
Well, certainly, it looks very different on the front lines than it does from a distance, and to imagine what the reality is for individual people and the needs that need to be met. When, if I can just describe, for example, something that was I describe in the book, we're trying to care for these very sick people with COVID,
Mm,
and there's nobody to feed the residents of the home who are not able to feed themselves. And so we were dealing with trying to keep oxygen levels elevated, and manage fevers and other medical issues. But there was nobody there to actually just be able to provide water and food to these sick residents. And so, from a policymaker's perspective, to understand that what is often seen as the least high profile of the health workforce is these personal support workers who do the huge proportion of the work, and to realize that you can have all of the emergency departments and ICU beds ready that you like, but if you don't actually have these frontline health workers, who are paid very little and put themselves at enormous risk, if you don't have those health workers available, then people will die.
mm,
So those are the kinds of things that I certainly witnessed firsthand, what that looks like. And we've had a big conversation about that, but I don't think that it's still raised to the same level of attention as some of the more high profile needs in terms of hospitals, et cetera.
right, right. And as we sort of enter into the winter months, I know here in the States we're preparing for a second wave, so to speak, and that now would be a good time for the lessons we learned in the spring to really kind of kick into high gear.
Well, exactly. And, certainly in Canada, as in the States, although I think we've even been worse hit from the point of view of long-term care facilities for
Right.
older people, the number of deaths that are so disproportionately affected in those areas is something that, we all learned and took note of, but, have we actually put the measures in place in terms of making sure that the staff are there, and all of the equipment and personal protective supplies are there for trying to make sure that things aren't as bad
Hmm.
as they were in the spring.
Right. Sridhar, I want to jump over to you. In the chapter you wrote, you argue that two methods for dealing with the spread of the virus, contain and control, and the use of forecasting models, fail to establish equitable protections. Can you explain each method and what you found kind of went wrong with those?
So the two things. The first one, in terms of the contain and control approach, in infectious disease epidemiology, there's been a long-term prevailing model is that the way that you deal with an outbreak and also infectious disease in general is that you identify the cases, you isolate them, you trace any contacts, and you try to control any new infections. And the idea is that you would treat the individual, or if they pass away, then you want to make sure that you control the infections to a certain area. What happened in the beginning of this pandemic is that there was an effort to contain and control, and it didn't work. And one of the most significant parts of this pandemic was that in the beginning, the Chinese government implemented a quarantine that was unprecedented in the history of infectious disease control, which is that they tried to quarantine 10 million people or an entire city in a very rigorous way.
Hmm.
And then they also moved on to quarantine other big cities of many millions of people, six or seven different cities, and they started to do that. And at that point, there was really no scientific way to evaluate whether that kind of quarantine and contain and control approach would actually work. And it eventually clearly didn't work, because what people did is that they kept moving, or they left the country, and many people who were infected actually went from Wuhan to other major international cities. So there is a real question about whether that sort of contain and control approach at a very local, what might work at a very small level, at like a household or a neighborhood level, if you implement it at a city level, or a huge sort of mega metropolis city, um, you know whether that was even justifiable, and in fact it made the situation worse.
Hmm.
The second thing is that when you have an outbreak of a novel agent, in this case, you have a SARS-CoV-2, and we didn't know what it was in the beginning. What you want to do is you want to try to get some basic facts, and so you want to know first, basically, what the case fatality rate is. So if somebody is infected, how many of those individuals, die as a result, and you want to know how quickly they die. You also want to know how they pass on, how many people get infected for per case. So you want to know essentially the reproductive rate, or the infectivity of the virus. What happened was that infectious disease epidemiology has a fairly, in the beginning, many decades ago, started in a very simple model. It's called the SIR model, which is that you identify how many people are susceptible, and then you sort of calculate, based on these different rates, how many people will get infected based on the rate, and how many people will eventually die, and how many people will eventually recover. And so, based on these simple SIR model, or these basic models, the modelers from Imperial College in the beginning of, I think, March, forecasted that there would be 200 deaths in the UK if nothing was done, and then they forecasted there would be 2 million deaths in the US
Right.
if nothing was done. And this is what really motivated so much of the panic and significant sort of lockdown recommendations, etc. What they got wrong, and what we've known for over decades now, is that everybody in a population is not equally susceptible, because of both biological and social reasons. Just like we are not equally susceptible to a chronic disease, not everybody is equally susceptible to an infectious disease. And that lack of appreciation of the inequality of susceptibility, basically politicians and all the people thought that everybody in society is equally susceptible, and therefore they would then motivate the solution would be to just shut down the entire society. Now, if we had a better understanding that actually there is in pre-existing inequalities in vulnerability or susceptibility to infection,
Mm.
and even if you get infected, there are different kinds of inequalities, both biological and social, that make it less or more likely that you will become sick, and then less or more likely that you will die. All of those things would give you a much more detailed and comprehensive and relevant set of information for you to implement policies. And if it was only after people started dying that suddenly it became clear, oh, it's actually very older, sort of elderly people that are dying, and it's actually Black and ethnic minorities that are dying. It's, so it's all of those things that come after people died that suddenly that politicians and policymakers started saying, oh, everybody's not equally susceptible. So
Right.
I think we've moved on from that. Now the forecasters and modelers are trying to incorporate both biological inequalities or diversity as well as social inequalities into their modeling to predict how different kinds of policy interventions may impact that or could impact that.
Okay. Excellent. Um, Sophie, in your chapter, which is titled Systemic Discrimination in Government Services and Programs and Its Impact on First Nations Peoples During the COVID-19 Pandemic, you write, the decision and remedial orders of the Canadian Human Rights Tribunal regarding Canada's inequitable funding of children's services for First Nations families provide a comprehensive roadmap of the federal government's legal obligation for the funding and provision of measures designed to prevent and respond to health crises. Could you walk us through some of the main stops on that roadmap?
Yes, sure. First, I should give you just a little quick background to the context of this case. So, in 2007, the First Nation Children's and Family Caring Society of Canada and the Assembly of First Nation lodged a complaint against the Government of Canada under the Canadian Human Rights Act, alleging discrimination on the basis of race in the provision of child and family services to First Nation children and their family. The government tried to solve the case unsuccessfully. In 2016, the tribunal released its decision, which upheld all the allegations of discrimination.
Mm-hmm.
And in its ruling and the following 9 remedial orders that were rendered since, the tribunal drew a detailed roadmap to guide the Canadian government in complying with its human rights obligations, which provides clear landmarks for the government to prevent and to respond to public health crises, such as the public health crisis we're currently facing with COVID-19. And I would say there's four main landmarks in that decisions that are very useful. The first one is that measures taken in response to public health crises, such as the COVID-19 pandemic, must reflect the cultural, the historical, and the geographical needs and circumstances of the different communities. For instance, governmental response should take into account like that the community is an urban community or a more remote communities. It should take into account the specific demographics of each specific communities and also the language spoken there to communicate in a language, in indigenous language, for instance, if
Mm-hmm.
the language still understood within these communities. So the message basically is that there's no one fits for all solutions, and that response should take into consideration special circumstances of the different groups and their specific needs. The second landmark is that new public money must be allocated to fund services for First Nations communities. So the additional costs associated with responding to public health crisis cannot be offset by cutting into existing services and programs. So you cannot, for instance, take away from the housing budget to fund public health, right? You need to invest new money to improve sector by sector without creating vulnerabilities in some sectors to advantage others. The third landmark would be more specific to that case, and it's that services and programs for children must be culturally appropriate and safeguard their best interest. And the fourth, and one of the most important landmark, is that substantive equality, according to the tribunal, cannot be achieved through ad hoc and piecemeal measures. So ending systemic discrimination for First Nations people require immediate and effective strategies to comprehensively and holistically address all inequities in government services and programs. So these would be the main landmarks.
Okay, excellent. Yeah, and I'm wondering if there are elements of the strategy that translate more broadly into other underserved groups. And I'm thinking kind of what we just heard Sridhar explain, particularly with the forecasting models and failing to sort of account for the way different populations are affected in different ways, or maybe more vulnerable than others in situations like this. But can has this strategy sort of overlapped into other underserved groups as well?
Well, while the case is specific to First Nations in many ways, I
Yeah.
think at the level of broad principles, it is highly relevant for policymaking regarding many other undeserved group. Especially, I would say, in order to be efficient and to uphold human dignity, government policies and measures should be tailored to the needs and circumstances of the groups to which they apply. For instance, let's take the example of public health directives and the ones especially pertaining to the use of public spaces, to physical distancing, or the rules on isolation when they're enforced on some populations may be really inefficient. So, for instance, trying to enforce public health directive pertaining to the use of or forbidding the use of certain public space on homeless people, for instance, or obligating people living in homelessness to isolate will not be very efficient and will actually risk to aggravate the marginalization and the oppression experienced by these individuals. So this is one concrete example that shows how we need to take into account the specific needs and circumstances that are specific to all the groups that are particularly vulnerable to COVID, in order for the measures to be efficient and uphold human dignities and human rights. Moreover, I would say, like, another landmark that I think is very useful and should be taken into account in policy making in the context of COVID is that ending discrimination and realizing substantive equality require to address all inequities at the structural level, to tackle the root cause of inequalities rather than simply treating the symptoms, right? So, for instance, a lot has been written about the precariousness of the largely racialized workforce working in our food supply chains, notably in meat processing factories, for instance, providing temporary relief, for instance, like financial relief that would be punctual in this case, would not resolve the more basic structural issues that this workforce faced and that makes them especially vulnerable to public health crises, such as we see right now through the COVID-19 context.
Jane, I feel compelled to kind of come back to you. Is there anything you care to kind of add on to what Sophie just commented on?
Well, I think Sophie has definitely done a great job giving a comprehensive overview of what happens when vulnerabilities become additive. Certainly, we've seen that in multiple groups here, as you have in the U.S. In terms of she speaks to the issues around Indigenous populations, but we're also certainly seeing our highest numbers here in Canada in fairly dense cities, where we're seeing that racialized communities are mixed with the challenges of the workforce, and the fact that the agri-food workforce in particular is one that's been hit hard, and then combine that with the fact that those same workers are often the ones who are working in our healthcare institutions as well. So we've seen a real disproportionate effect of the pandemic on certain communities and certain neighborhoods for all of the reasons that we've understood for a long time that some people will be more vulnerable to a virus outbreak than others.
So you mentioned, so there are workers who are working 2 different or 3 different jobs. Is that what I'm hearing? In terms of the agri-food workers who may also work in long-term care facilities, for example.
Well, sometimes,
Yeah.
or sharing the same households.
Okay.
The people that are involved in the essential workforce, which is often the food workforce, the health workforce, transportation. That we're seeing households where there are people that can't stay home.
Mm.
People describe now the concept of pandemic privilege, and that the people who are calling the most loudly for people to stay home are ones who have the privilege of doing so, where in fact other sectors of the population where people are don't have either the privilege of being able to stay home in order to be able to continue to put food on the table, and or society is completely dependent upon them. And so we're seeing that is disproportionately affecting particular neighborhoods within our cities, and those happen to often be the same neighborhoods where we have the highest density of housing. And so
Mm.
it's these risk factors become additive, and it can be very hard then to tease out what the public health intervention could be that would allow people to be able to stay home when in fact we're dependent upon people not staying home.
Right. Sridhar, in terms of preparedness, what did you learn about various countries' vulnerabilities? I kind of want to get your global take on this. Were there many things that governments thought would naturally happen uh, because of how they thought they were prepared, but actually did not happen? And can you elaborate on that a little bit?
Sure. I think it's not a very complicated or exciting observation. So, what I'll tell you basically is two things that I have to say. One is that um, it's astounding to me that so many countries that are considered to be the most industrialized, developed, and richest actually don't have an understanding of public health
Mm.
as a concept and public health infrastructure and system. And what's happened is that overwhelmingly the focus has been on healthcare and healthcare systems rather than public health system. And I think that this is clearly seems to be one of the big differences between the other industrialized countries, namely in Southeast Asia, and how well they responded and quickly and effectively to the threat and got under control versus other rich countries, namely, in European countries and then North American countries. And you can really see that in terms of both the weak public health infrastructure, and we can go into very many details about what that might look like, but also just a general understanding among public officials, politicians, and the public about the concept of public health, and what public health means and what it entails and what are the different kinds of indicators of public health and how does public health improve or worsen, etc. And I think that this has become a central issue, is that we're going to sort of need to spend a lot of time sort of improving our societies or the countries that are worst affected. This is remarkably different than what something like a pandemic preparedness index looked like. They looked at various kinds of issues such as resource mobilization and various kinds of healthcare and whether epidemiologists will be able to sort of go forward and carry out tests and things like that. And and as you probably know, the countries that had ranked the highest on these indexes actually are the worst affected by the pandemic, means that they've actually performed the worst. So these resources that supposedly were going to help them are actually completely overwhelmed by these fundamental factors, such as the lack of understanding of public health and the public health infrastructure. The second thing I have to say, and it's also a very boring observation, which is that our politics are off. The politics where one would hope and one would assume that one of the central roles of a government is to protect the health and well-being of its citizens, and that politicians from the leader on down would have one of their central commitments to be protecting the health and well-being of citizens. And what we have seen, I think, at least in the worst performing countries, is that politicians have multiple interests, including self-interest, and there seems to be a profound lack of trust between citizens and politicians. And then also, it seems to be, at least from a personal observation, that this basic idea that you would hope that the most highest elected political officials, their primary mission is to serve the people, is just simply has shown to be simply not true.
Yeah.
I think that's, what else can you say about like the state of politics as being at the worst if you don't have good political leaders? And what we've done is that we've shifted our focus onto experts and thinking that experts will solve the problem. But the problem, is that basically experts are only, the side information to the main actors, which are politicians and policymakers, and they will do what they want to do with the expert advice. And so fundamentally, I would say public health infrastructure and the concept of public health has been missing. And second, the political leadership and political values has been profoundly shown to be deficient.
Mm-hmm. I'm wondering, Sridhar, real quick, if you could just kind of put a finer point on healthcare versus public health for our listeners. The difference basically between the two.
Sure. So, one of the ways to think about it is that, if you are a parent, or if you, as an individual, is that, you think about healthcare as something that you go to when you're sick, and profoundly when you are ill, healthcare is profoundly important. And then also we have this thing, where if you've got a young child or something like that, you want to make sure that you can prevent certain diseases. So you get various kinds of immunizations to ensure that they are protected from these infectious diseases, etc. But there's a whole other world of determinants of disease and disability that we protect individuals from. This is everything from, not only the quality of the environment and the quality of the food, in terms of road safety, in terms of ensuring that there's good environmental conditions and good housing conditions. These are all determinants that impact our vulnerability or exposure to different kinds of disease and disability. But beyond that, what we've also started to recognize is that it's not just public health isn't just about protecting us from harmful exposures, but actually how we relate to each other also impacts how disease impacts us. So in terms of our stress levels and how stress impacts our biology, and the way that we feel stress is based on, how we are treated by other people and how our work environment treats us and how we, our poverty, our racism, etc. All these things cause and distribute disease and illness. So overwhelmingly, while all of this is profoundly shaping our vulnerability and exposure to disease and disability, our conversation is all about, basically sickness care, about like once you get sick, what is the availability and access of healthcare for you? When what we should be doing is focusing on the determinants of disease and health, and also profoundly, perhaps also the determinants of good health.
Okay. Excellent. Thank you. You just heard from the Honorable Jane Philpott, Sophie Theriault, and Sridhar Venkatapuram, co-editors of the book Vulnerable, The Law, Policy, and Ethics of COVID-19, published by the University of Ottawa Press, the sponsor of this series. Join us next week when I continue my conversation with Jane, Sophie, and Sridhar, addressing issues of vulnerability and equity in pandemic response and recovery.
and they imagine that they're making a policy for a certain individual, usually middle class. They have housing, they have a job, and they have this and they have that. And that policy will then be implemented because they're also thinking this is the largest group of people, so they are also the average standard citizen, and then we'll deal with everybody else later, or as a separate special policy consideration. So it's a condition of equity, I guess. If we were thinking philosophy, this is the idea that public policy is about the greatest number for the greatest good. And so we will try to act quick and help as many people as possible, and then we'll deal with all the exceptions and the consequences later. And I think that this is profoundly mistaken, and it has a lot of problems, and we are seeing what those problems are.
If you like what you hear, rate us or give us a review on your podcast platform of choice. And if there's a topic you'd like us to cover, drop me a line. I'm at bmickey@ala-choice.org. As always, sponsorship and advertising for the Authority File podcast are handled by Choice's advertising manager, Pam Marino, and all of our episodes are produced by Choice's senior digital media producer, Mark Dirks, and digital media assistant, Sabrina Kofer. That's all for this week. Thanks for joining us.